Resident of New Delhi, housewife, postgraduate by education, and history given by patient and her husband. Date of admission was 23rd of May 25 and date of examination was 27th May 25. She presented with complaint of swelling over lower limbs for 1 month. Then the history of presenting illness, I would like to date back my history in 2021, 3 years back, when she underwent a routine checkup, and on routine checkup she was found to have increased blood sugar, for which she consulted nearby physicians, and she was prescribed some oral medication. The name of medication was not remembered by the patient, and she used to take 2 times tablet for 3 months. Then she left the treatment by once. At that time she had no history of polyuria, polydipsia or polyphagia, no history of blurring vision or numbness, tingling sensation, no history of swelling over lower limbs. As per patient, her BP was normal at that time. Then she was apparently well for next 1 year. In 2023, she had history of fever with chills, which was associated with increased urine frequency and dysuria. However, there was no history of flank pain, hematuria, graveluria, pain abdomen or loose stools, for which she consulted a nearby physician, and she underwent a urine test, and as per patient she was told that her urine showed pus cells, and she was prescribed some oral medication, which for which he took for 5 to 6 days. However, she had a history of 3 to 4 episodes of similar episodes of that illness, which was persist for 6 months, and every time she was prescribed different antibiotic. However, on direct questioning, she refused that she underwent any urine culture or any other investigations. After that episode, she was apparently alright for 2 years back with no history of any UTI, and as per patient, her BP was normal at home, which was measured by automated machine, and her sugar level, which was done occasionally, was also normal. Now in April 2025, after 2 years, where patient had generalized weakness, fatigue and swelling over lower limbs, for which she underwent some routine test, and she was found to have anemia of hemoglobin 6.8 milligram per deciliter. For which she consulted a local physician, and on the presentation her BP was 240 by 110 on OPD basis to the nearby physician, and she was advised for admission, but patient refused, and she was prescribed some test and some oral medication, and the name of which was not remembered by the patient as well as her husband. And the swelling, at that time swelling was gradually in onset, and up to between ankle and knee, and there was no redness or no arrhythmia. She had no history of shortness of breath, orthopnea, PND or any chest pain at that time, no history of cough with or without sputum, no history of jaundice, decreased appetite, pain abdomen, and after prescription by that physician, she underwent some routine test, and she was found to have a serum creatinine of 2 around 3 to 4. She doesn't remember the exact value.
Which year was this?
Sir, 2025 in April. And as per patient, her swelling was resolved by the medication given by the physician. And she also tell that she was also advised for eye examination, which revealed the early changes of a diabetic in her eye. And she was advised to consult her nephrology. However, on 14th of May, she was apparently well during that period, and on 14th of May, she was admitted at Fortis in view of ghabrat and restlessness. However, she had no history of chest pain, shortness of breath or palpitation, no history of chest pain, no history of shortness of breath at that time. And as per patient, her BP at that time was systolic 200 mm of Hg, for which she was admitted in ICU, and she underwent some investigations, ECG and echo was done, which was normal as per patient. And as per patient, she was told that her serum sodium level was low, and so she was managed with some IV injections. And she was discharged on 16th of May after 2 days and advised to take some extra salt. In current, she was again admitted on 23rd of May in view of swelling, and this time the swelling was up to ankle with no diurnal variation, and there was no history of pain, redness, and she also complained of facial puffiness, and as per patient, she also has a decreased appetite for past 15 days, as well as decrease in sleep for past 15 days. There was no history of froth in urine, hematuria, nocturia, or graveluria, or frank pain. No history of decreased urine output. No history of shortness of breath, palpitation, orthopnea, PND. No history of cough with or without sputum. No history of fever, sore throat, any ear discharge, or any body ache. No history of nausea, vomiting, pruritus. No history of constipation, abdominal fullness, or yellow discoloration of eye. No history of skin rash, joint pain, or oral sensitivity, or dryness of mouth. No history of intake of any painkillers or any alternative medication. And she also had no history of any blood transfusion, no history of burning feet, numbness, or dizziness, and no history of any focal neurological deficit or headache at that time. During hospital course, she was told that her BP at that time was, this presentation was also raised, and it was 200 by 100 mm Hg. And on presentation, she was told that her serum creatinine was 5, and which was increased to 7.1 during the hospital course, and she was managed with some continuous IV injections, with which her urine output increases to 300 ml after every 3 to 4 hours, and she was also advised to undergo fistula creation, and she underwent left AV fistula creation on 26th of May. And in past history, she had no history of any chronic, no history of any stroke, hypothyroidism, any cardiac illness, tuberculosis, or renal stone in past. Personal history: patient is married, vegetarian with normal bladder habit, with a history of decreased sleep in past 15 days.
History of?
Decreased sleep, sir, altered sleep. And in obstetric and gynae history, sir, she had 2 living child, and the male one is a male child which is 35 years old with full-term vaginal delivery, and second child is female 31 years old with full-term non-vaginal delivery with no significant history of any complications during the her antepartum follow-up, and she achieved menopause at age of 52. In family history, except her mother had history of hypertension, no other family members had any chronic illness or any renal illness.
Any illness? You should specifically mention diabetes, because you meant
Yes.
diabetes or chronic illness.
Yes.
Okay. Right. So, would you like to just sum up in,
So to summarize the case, this is a 58-year-old female with history of diabetes for 3 months, for which she was not on regular treatment.
3 months or 3 years?
3 months, sir. Only she took treatment for 3 months, then she left by itself. 3 years history of diabetes, 3 years, but not taking
History of
medication.
diabetes for 3 years.
Yes,
Yeah.
So with history of recurrent UTI 2 years back, and found to have uncontrolled
Renal UTI?
recurrent UTI, sir.
Recurrent.
And found to have uncontrolled BP in April 2025 with renal dysfunction and anemia, having swelling lower limb, which was resolved by likely diuretic, followed by she developed hyponatremia, likely diuretic induced, and again she developed swelling over lower limb with raised blood pressure at that time, and also had history of decreased appetite, and for which she received IV diuretic and other medications, and underwent left AVF creation on 26th of May.
Okay. Anything else in the history, anyone? Would like to go?
Anything he has missed in the history? She's diabetic.
You saying something?
Well, huh? Or
Sorry? Retinopathy is mentioned. Yeah.
anything else?
He mentioned NSAIDs. He mentioned anything else. Vaccination history should come. Okay. You should. That tells the patient that The
Yes.
examiner should realize that you are aware that vaccination control, and obviously you should know all the vaccines. Take it.
History of autonomic dysfunction you haven't mentioned, right? 3 years diabetic. Some patients they can have at presentation diabetic nephropathy, and that history is also important.
So how will you elicit now? Autonomic
no.
usage.
Sir, to look for autonomic dysfunction, sir, we will ask
History.
History.
history. Sir, any history of postural hypotension, and sir, any history of abdominal sweating, and sir,
Sweating during
eating
eating or in the night.
in the night.
The
And
patients they complain that while they are sleeping, even in the cold, the whole bed is wet.
Right. Yes. And so, if a patient is a male, then we will ask for erectile dysfunction and sir, any and resting tachycardia. Patient has palpitation while
Intermittent palpitation of and on. Right. So based on the history, what do you think you are dealing with? What's your syndromic diagnosis?
Syndromic diagnosis likely, sir, patient is a syndromic diagnosis or chronic kidney disease,
Okay.
and the etiological diagnosis will be diabetic kidney disease.
Okay.
And then the second DD may be sir acute on CKD with sir acute factor being sir accelerated hypertension that she had with fluid overload.
Okay. So tell us why you think of diabetic kidney disease and whether there is something odd for diabetic kidney disease.
Sir, as this patient is a 56-year-old female, and likely in this age, patient have type 2 diabetes mellitus, and basically patients with type 2 diabetes mellitus may have diabetes illness quite earlier and had a long course before they get diagnosed. So and also they have some patients have.
No, so we are asking in this particular patient, why do you think that she's got diabetic kidney disease? 1, 2, 3, 4.
Points in favor, points
Points in
against.
favor, and is there
Points
anything
against.
a diabetic kidney disease or not? We agree with the possibility first diabetic kidney disease, but now you have to justify your diagnosis, no?
So patient has diabetic retinopathy, sir, and patient has swelling likely due to the proteinuria. Urine examination was done by me, and it shows
Hey, with your history only, na? We haven't proceed towards urine routine, na?
so patient had swelling, edema, and worsening of kidney functions at in April our serum creatinine was at around 3 to 4, and in May our serum creatinine was around 5. So declining in GFR, and patient has hypertension.
But this hypertension, we can agree to everything, but this sort of rapid progression would actually be odd for a diabetic kidney disease. No? What is the normal rate of progression of, first of all, tell us what is the normal rate of worsening of kidney function in a normal individual?
Sir, less than 3 ml per
normal individual.
Normal individual.
Sir, normal
aging and kidney disease.
0.75 ml per kg per year, sir, declining.
So less than 1.
Less than
After which
40
age?
years, sir.
Huh?
After 40 years.
That is important, na?
After 40 years. Now come to average kidney function decline in a diabetic individual.
Sir, less than 3 ml per minute as GFR every year.
So, in this particular lady who was diagnosed just 3 years back.
So maybe she was off antihypertensive medication, and as per patient, her blood sugar was quite low. This may indicate that patient having underlying nephropathy is going on.
Yes. What else could have contributed to the rapid decline? You've told us one is accelerated hypertension. Blood pressures have been very poorly controlled.
Yes, sir.
What else?
Sir, edema itself.
Edema can't contribute to worsening. Now, don't get into problems. You're doing well so far, but why get? What else? You yourself told one history. UTI.
UTI, sir.
Huh? So she had UTI. She had poor blood pressure control. Sugar control we don't know.
Yes.
But I don't know when she had normal renal functions, if you can, because you have told us that the first time the renal dysfunction was detected was in 2025 only.
Yes, sir.
So the progression has been a bit rapid, but it's not. Anything, so anything else that is odd for a diabetic kidney disease? Progression is definitely a bit rapid. But yes, we can explain, as you said, that what else? So no family history is there.
Yes.
Diabetes, for whatever
Running in the
reason,
family.
tends to run in family. So would you like to keep a non-diabetic kidney disease, or you're quite happy with diabetic kidney disease?
So maybe these patients could have, we can kept also, sir, non-diabetic kidney disease as rapid progression of EGFR. But sir,
Hypertensive, how long?
sir recently diagnosed hypertension, sir. 1 month, sir.
At the stage of history, yes, you can keep, although yes, but features are heavily in favor of diet. And you can say that many patients with diabetic kidney disease with NIDDM would have renal failure because it's a silent course that is there.
Yes.
Okay. So maybe she was not getting her checkup done, so it predominantly appears either at CKD or whatever acute on CKD. All right. So now we move on to the examination. Then we can come
Ideally,
back.
your diagnosis should be acute on chronic kidney
Yeah.
disease. Acute, you should mention accelerated hypertension and
Very
recurrent
true.
UTI. And chronic kidney disease, I will keep the possibility of diabetic kidney disease. Or you can keep non-diabetic kidney disease on diabetic kidney disease to get more marks. And non-diabetic kidney disease is basically because of there may be hypertension. If just like diabetes, the hypertension is also unnoticed. It could be underlying ischemic renal disease. So to score more marks, right?
The general practice at this stage of history, keep it broad based, and then
So on general physical examination, patient was lying comfortably on bed, conscious and oriented to time patient person. Cannula was in right arm, and there was dressing over left forearm. Vitals examination, pulse rate was 108 beat per minute, regular good volume. BP was 150/70 taken in right arm supine position. Weight was 62 kg and the height was 160 centimeter with BMI of 24.2 kg per meter square. There was pallor present, there was no ictus, no sinuses, no clubbing, JVP was noticed, and there was no pedal edema, and there was no any scar marks or any lesions over the foot. And on systemic examinations, and on respiratory examination, bilateral ear entry was present with the ear entry decrease on right side, and bilateral infrascapular caps were present more on right side as compared to left, sir. And CVS examination, S1, S2 was present with, sir, no added sound with no pericardial rub, sir. And apex bit could not be done as patient not permitted to. Apex bit was not localized.
carry on.
And sir, per abdomen patient, was soft with non-tender with, sir, no organomegaly. And CNS function, sir, high motor function was intact. Sensory examination was not done by me, sir.
Why?
बेसिकली पेशेंट को सर इको के लिए जाना था.
Sorry?
इको के लिए जाना था पेशेंट को सर, इको एग्जामिनेशन के लिए.
They're not cooperating for a. इनको बुला लेना था ना, they should have. Because, see, diabetic kidney disease is a very difficult case. You miss one thing, you are on a very slippery ground. Because diagnosis, so sometimes the examiner tells you, I am telling you he's got diabetic kidney disease, now move forward. That means you are in deep trouble. That's a warning sign. So, you have to try and elicit, okay, tell us now, what would you, let's say the patient is, what would you have done? What is 1, 2, 3 tests that you would have liked to do? You were not given the opportunity, we grant you that, but.
Sir, in sensory examination, sir, we will look for vibration, ankle reflex, then sir.
You brought you have na, and
Yes,
your tuning forks and hammers,
Yeah.
everything is there?
Yes.
It is okay.
Then sir, Fundus examination.
Okay. What else? Fundus तो हो गया चलो.
Fundus to neurological.
चलो, you want. What else? Something which was. Anybody else in the audience? What is
Vibration, touch,
Micro?
fine touch.
the sensory examination? Okay. What else? One more aspect.
Autonomic.
Yeah. Just give you
Orthostatic
a hint.
hypertension.
तो अब क्या 2 or 3 you should have bedside tests. So in autonomic examination, what do you test? There are tests that tell us.
So we will check sir patient's blood pressure at supine and sitting sir.
Okay. So you test the sympathetic arm, the parasympathetic arm. There are tests that tell you both. So you have to tell us which are the tests. So one is you said postural hypotension. What else is easily tested?
Did you have seen that? You haven't mentioned in your blood pressure.
No.
You haven't mentioned in your blood pressure. In general examination, you have done a lot of mistakes.
So एक तो ये बता दिया और क्या टेस्ट postural hypo और क्या करोगे? This is very simple. You should have 2 or 3 tests. As I told you, one parasympathetic, one sympathetic, one both, which you say that these are the ones I have done. So what are the ones that you are aware of? Tell us.
Anybody, if he is not able
Yeah,
to.
let's move.
Hanji?
Yeah, good. What else? Along with resting tachycardia, beat to beat variation. Same ना, वो तो उसी के साथ ही कर लोगे. So कौन सा आर्म टेस्ट करता है ये? पैरासिम्पेथेटिक करता है, सिम्पेथेटिक करता है. Okay. What else? So nobody has read about autonomic function test.
Gustatomotory, I think. Gustatomotory, sir.
These things will definitely ask in your diabetes.
Diabetic और क्या पूछेंगे? One of the most difficult cases I am telling you. So read up autonomic, okay? As I told you, so this is, I have tested the sympathetic arm, I have tested the parasympathetic. This test tells you both. All right.
Yeah, in general examination, you have mentioned your blood pressure, right? That should be in all the 4 limbs, right? You don't know. It's the diabetic kidney disease, atherosclerotic renal
Patient has,
disease.
sir, in left hand patient has sir AV fistula. That's why I haven't checked.
और
Okay.
क्या देखोगे जनरल फिजिकल एग्जामिनेशन में अब he is given you a hint that you have missed something. So what else you want to, or should we start asking you now? One chance you will get.
You will ask posture, you will see the blood pressure in all the 3
हाँ.
positions. You have to mention, if you want to score good marks, you have to mention each and everything.
How do you look for peripheral vascular disease?
So claudications.
Array, when general examination.
ABL, ankle brachial index, ABI.
And you haven't
Yeah.
mentioned all the peripheral pulses,
Pulses नहीं बताई आपने.
palpable or not palpable.
Peripheral vascular disease के बारे में तो आपने बताया.
You haven't mentioned, you have mentioned JVP not raised, and in examination you are telling bilateral crepes are present.
So minimal.
Crepes, if crepes are there, right, then some fluid is there. Either you are saying they are infective crepes.
No, sir, they were not infected. Sir, fine.
Then- So your finding should यहीं फंस जाओगे. You will trapped here only. You have to see any other thing you want to see in general examination. Your general examination should be from head to toe. You should mention you are practicing basically.
Evidence of hypercholesterolemia, sir, like xanthal asthma and arcus analysis.
You know the case, but you should examine the case that you don't know the case.
नहीं, you were not told the diagnosis.
Yeah, that's whatsoever.
चलिए और क्या क्या फिर? What else in the general physical examination? Look at the nails. Some of these ladies would, especially in females, paronychia may be there. And if the examiner picks it up, you'll be in trouble. More so in transplant patients, but even in diabetics. 2 categories where you should make sure look for paronychia is one is diabetic patient, the other is transplant patients. Okay? Carry on. What else?
The diabetic patients, they have very bad oral cavity. Have you seen any smell, dental care? These are important points.
No diabetic ulcers in the periphery?
No, sir.
Then you should say that there is no evidence. So the examiner immediately moves on, that here's a person who's. Chalo. ठीक है, urine examination, you are entitled to a urine examination.
Yes, sir.
Yes. Urine RM routine क्या था?
So I have done with dipstick.
Okay, you have done dipsticks. Okay. So dipsticks, you tell us, microscopy they'll tell you. ठीक है. In the exam, you might be asked to look at you might be given a urine sample or you'll be.
So protein was 3 plus and sugar was 2 plus, and so blood was negative, nitrites were negative, leukocyte was negative, ketone was negative, and there was no bilirubin and no urobilinogen. And specific gravity was 1.015.
1.015.
0.015.
Then what sample was this? Was a random sample or a first morning sample?
So random sample.
This is random. So you should specify. Okay. Maji, urine RM, do we have one? File मंगवा तो ली थी. Do you recall any? बता दो मैम. RBCs, we are interested in RBCs. No, routine. He is told microscopy is all we are interested in.
Sir, no pus cells, no articulation.
Okay, no pus cells, no RBC.
Protein was there, sir. Glucose was there. There was no RBCs. And
ठीक है बैठो बैठो आराम से ठीक है so no pus cell, no RBCs. Okay, now where are we? After, so now you have got a history, you have done a physical examination, you have got a urine test also. So what's your diagnosis now?
So still sir, diabetic kidney disease.
पहले तो syndrome तो बोलो, shortcut नहीं मारना है इस समय.
chronic
You're
kidney
doing well,
disease,
but that doesn't mean that.
Syndromic diagnosis, sir, chronic kidney
Yeah,
disease.
so here's a patient, 58-year-old lady who come to us, and I think she's got chronic kidney disease 1, underlying etiology.
Stage बताओ chronic kidney disease की.
So with that creatinine, sir, likely it's stage 5, sir.
बोलो. CKD stage 5, then?
ND CKD5 ND, sir.
ठीक. Then?
And any other possibility at as far as this? Only one possibility, CKD 5D, or
So
acute on CKD we just mentioned earlier. It's too early. You're just seeing her once, single picture, and you said so.
So many, within 2 months, she's
Such
having
a
to.
rapid progression. So many events have been there. So why not acute on CKD?
yes, sir, second.
Keep it. Many times we also at this stage we are not sure that we start the patient on dialysis, or we just follow them up, and you start seeing that the kidney function is getting better for just because you have, just optimized. So acute and chronic kidney disease, you have to bring in. There's such a rapid progression here. That is the single most important thing. You are telling in 2025 the creatinine was 3 to 4, and now it is double.
You have made the fissure also.
Yes.
Okay. So, all right. So now you start in. What investigations would you ask for to move ahead?
So complete blood count, sir, CBC, sir. Then sir,
So CBC. What are you looking for in CBC?
so we'll look for sir anemia, and also sir RBC indices, sir, to look for whether it's normocytic, normochromic, or microcytic hypochromic, or anything other else. Then sir kidney function test, sir.
No, अभी और क्या है? CBC में सिर्फ
CBC
anemia,
में और क्या
hemoglobin.
Sir.
You're happy with that?
नहीं sir.
और क्या है?
Then sir leukocytes, sir.
Huh?
Is there is any rise in sir leukocytosis? As diabetic patient may don't have sir any symptoms like fever and all that.
क्या था? Do we have the CBC?
yes, sir.
बताओ.
7.4, sir, hemoglobin.
बैठ के कर लो. Enough. Loud enough. Just
PLC was 10,000, 290 platelets, sir.
10,000.
Yes, sir. Background indices were normal, sir, within normal limits. Then iron profile was.
He didn't ask for that anyway. हाँ जी आप बोलो.
Then sir Kidney function test, sir.
Kidney function test. What do you mean by kidney?
Sir, blood urea, serum creatinine, then sir electrolyte, sodium and potassium.
That's all? Nothing else? एक बार ही बोल दो ना जो टिक कर रहे हो, एक बार ही ऑर्डर करते हो या दो दो करके करते हो?
एक बारी सर लिवर फंक्शन टेस्ट सर.
अरे अभी पहले इसमें तो बता दे.
और क्या बचा है इसमें? सोडियम पोटेशियम के अलावा यू नॉट इंटरेस्टेड इन एनीथिंग एल्स?
Chloride.
Chloride. What else? No other electrolytes?
Sir, calcium, phosphorus.
So why are you? Tell us. चलो. What else? Calcium, phosphorus. What else?
Albumin, sir.
एक ही बार बोल दो ना. हाँ.
So serum albumin, sir.
Okay.
Then sir.
बता दो जी. Any? Do you have some readings?
Sir, phosphorus was 9.1, calcium was 10, uric acid was 8.7, sir.
यूरिक एसिड तो मांगा ही नहीं. He forgot.
Sodium potassium was normal, sir. Later on stages. Earlier she came with 118.
Okay. Right.
Then sir.
What else? LFT he asked
LFT.
for.
Sir, albumin was 3.2, OTPT was within normal range to be normal.
Then sir.
क्या है ये? Anything funny in this so far? What are you finding?
So there is a rising of sir calcium and phosphorus both are sir. Phosphorus is raised, sir. Hypophosphatemia with sir anemia and sir.
So there is anemia, there is hyperphosphatemia. What else?
So if we corrected calcium will be also slightly raised, sir. No, it's normal. Yeah. Then sir albumin is slightly low, sir. It's 3.2.
So there is hypoalemia.
Yeah.
What about the calcium? You have not commented about the calcium.
So calcium is 10, sir, and the corrected calcium will be, sir, slightly raised, sir. It's 10.64. So it's raised, sir.
There is hypercalcemia. So what else? Any other? Now, in light of this, what other investigations do you want?
Sir, I would like to, sir, do, sir, intact PTH and, sir, vitamin D, sir, 25 vitamin D, sir.
Okay.
And, sir, as patient,
Do you have
sir,
these readings?
Sir, IPT was 29.
29. Okay. 25. Right. So what does this tell you? PTH of 29.
so it's,
What value will donate a dynamic bone disease?
sir, it's less than, sir.
What is normal value of PTH?
So it's vary with the, sir, stage of CKD, sir, which are
I am asking you normal value. Bearing.
so 35 to 70.
Huh?
35 to 70.
Okay. Now the question is, what is the considered normal value for dialysis patient? What you want to answer, that is the.
Sir, as per KDIGO guidelines, sir, they are just targeting, sir, 2 to 9 times the upper value of, sir, PTH.
PTH in
So in dialysis patients, sir.
non-dialysis patient?
So in non-dialysis patients, sir, the target would be, sir, in CKD 500, it's 150 to 300, sir, and in CKD.
There is no clear-cut guidelines. There is no definitive value. What should be the appropriate level of PTH in non-dialysis patient?
Well, what is this value? 29.
So 29 is low, sir.
It's suppressed.
So what does it mean?
So maybe, sir, this patient has a. So in hypercalcemia, suppressed the, sir, parathyroid hormone. That's why maybe this
Hyperphosphatemia bhi tha?
hyperphosphatemia also, sir.
So what sort of metabolic bone disease?
So it's
Maybe there.
likely, sir. Say dynamic bone disease, sir.
Could be
this
a
patient may
dynamic bone
have-
disease, but
maybe she receives
In CKD patient, PTH less than 100, there are more chances of
a
adynamic bone
This is
disease.
you got hypercalcemia also already in setting. Whatever the reason. Okay, but let's move forward quickly. What else do you want?
So urine spot urine protein creatinine ratio, then sir HbA1c level to look the, sir, diabetic control of the patient. Then, sir, as patient is anemic, sir, I would like to do, sir, iron studies as well as, sir, to look other causes of anemia like vitamin B12 and folate level. Also, as patient is vegetarian, she may have, sir, vitamin B12 deficiency or folate deficiency. Then, sir,
Do we have what are the reports available?
Sir,
And folate, but not done yet. Okay. But yes, you should ask for that. Good. So now she's given you this
So
T sets of 28% with a ferritin of 7.
780.
So what do you think it is?
Iron is 28, right?
Percent saturation, sir, 28.
28%.
Iron is
28%.
serum iron?
49, sir.
49.
So ferritin is slightly high, although iron and T sets were low, so though
T set lower.
T sets are 28 and in CKD 5ND patients, it's normal, so more than 16, so it's normal.
The anemia of chronic disease, what
Yes,
else? Chalo. Simple. Why are you getting so nervous there? Okay. What else? What others investigations we want in this?
So ultrasound,
Ultrasound. What?
so USG whole abdomen, sir.
Whole abdomen. Okay. What are you looking for?
So as patient has diabetes mellitus, such patients may have risk of NASH. That's why they may have altered liver echo texture also. Then and to look for the status of kidney.
Okay. What
Kidney
else?
shape, size, and echo texture and CMD, sir.
Yeah. What
So,
else?
Patient has a history of recurrent UTIs or USG PVR, sir.
PVR. Good. And you would also look for some other, like, does she have a kidney stone
Sir,
linked to the
yes,
UTI?
yes.
So these are the things that you would ask the radiologist for, right? Okay. Ultrasound.
The ultrasound kidney size is 5.9 and 7.9, sir.
Okay.
Right and left kidney.
Bladder, do we have any information on the bladder? What is
Bladder, sir, normal.
PVR? Is specifically for PVR. But not done. Sure. But yes, we should look for the PVR.
Then, sir, blood gas analysis, sir.
Blood gas analysis, 7.4 pH, PCO2 23, PO2 81, bicarbonate, sir, at that time was 16, sodium was 118, potassium was 4.2. Lactates were normal.
So what do we have in the blood gas?
So mixed gas metabolic acidosis, basically, sir, patient has a metabolic acidosis with compensatory respiratory alkalosis.
So metabolic acidosis is surely there, right?
Yes.
Okay. What else do you want? Are you finished?
So 2D echo, chest X-ray.
Yeah. Echo.
Sir, patient had LDH with ejection fraction of 55. PA pressures were raised, sir, 54, and IDC was 1.9 non-collapsing. There's no RWM.
What else?
Vial marker, sir.
Vial markers बताइए जी. ठीक, चलो. What else?
So to look for the evidence of neuropathy, sir, we can ask the patient for neurological examinations, NCV examinations, nerve conduction elastic examination.
Okay. What else? Autonomic function test. फिर वहीं फंसोगे. What autonomic? वो तो आपने हिस्ट्री में पूछ लिया. वो कुछ you have done some examination. What are the autonomic function tests that you will do? Objectively, that is all subjective, no? You're doing.
Yes.
You said no beat to beat variation. ECG limb leads लगा के, then you what will you ask the patient to do? tilt test क्या होता है? So you should read again these autonomic function tests that with the same this thing. So this I would do for the parasympathetic. I would do. ठीक? चलिए. Right. So now based on whatever you have investigated, what's your diagnosis?
Sir, diagnosis of the patient would be syndromic diagnosis, chronic kidney disease, stage 5 with etiologically diabetic kidney disease with aerodynamic bone disease with hypertension and fluid overload, sir. With anemia of chronic disease.
With
Anemia of chronic disease.
anemia तो बोलोगे? Right. Yeah. What else? Okay.
Again, you want to revise something in your diagnosis?
Or sir, it could be acute on CKD. It's
Then CKD 5, then diabetic
That-
kidney disease. Okay, next.
diabetes mellitus with diabetic kidney disease with diabetic retinopathy with anemia of chronic disorder with aerodynamic bone disease with fluid overload and
Okay. So
What is odd? So far now we have all the investigations. What is odd for a diabetic kidney disease here so far? I'm not saying.
sir, one thing, sir, that is small kidney. Usually, sir, diabetic patients not have small kidney at that early stage.
Yeah,
Although
so
there may be chances that they may have small kidney, sir.
Yeah, but that is a bit odd for a diagnosis of diabetic kidney disease. Okay. What are now? I would reframe the question. So, in a diabetic patient who's got kidney disease, what are the pointers towards a non? Now we are moving away from this patient. What are the pointers towards a non-diabetic kidney disease? When you
Sir, pointers may be, sir, rapid progression of serum creatinine, sir, rapid rising of serum creatinine or decline in eGFR, and then sir, massive proteinuria in absence of hypertension, and sir,
massive increase, rapid increase in the proteinuria.
yes, sir, rapid
You have one
increase,
reading and the next reading doubles. So,
rapid increase in proteinuria, sir, rapid
Number
rising
three.
of serum creatinine, then sir, patient has a rapid rising of serum creatinine with
वो तो हो गया दो बार मत बोलो ना.
creatinine होगी, protein हो
patient
गया.
has sir renal dysfunction without diabetic retinopathy. Then sir,
How many patients of diabetes have diabetic nephropathy, have diabetic retinopathy?
sir around sir in sir can you repeat, sir?
Diabetic nephropathy, how many patients will have the diabetic retinopathy?
Sir, around 50 to 60 patients of diabetic nephropathy have, sir.
60%.
Yes.
60% you have to ask.
Yes, sir.
same
50 to
question.
60% patients of diabetic nephropathy have, sir, diabetic retinopathy.
No, the question is reverse. Diabetic retinopathy, how many patients will have the diabetic nephropathy?
Sir,
For type 2,
type 2, sir, around 30% patients, sir.
30 to 40%. Diabetic retinopathy, diabetic nephropathy will present in 30 to 40.
Yes.
In type 1, almost 100%.
100%. More than 90%.
So we're talking. So you said absence of retinopathy. What else?
Then, sir,
Number
patient
four.
has, sir, active urine sediments in
Don't
urine.
say active urine sediment. You have to see what.
RBC, sir, RBC in urine, sir. Or patient has, sir, history suggestive of, sir, some systemic, other systemic disorder also.
Microhematuria, and especially if it is dysmorphic RBCs. That is all. No, that microhematuria can be there. ठीक है? चलिए.
Non-proteinuric diabetic kidney disease,
Sir,
what is that? And how many percents they have? They can have?
Non-proteinuric diabetic kidney disease, sir, patients having, sir, eGFR less than 60 and, sir, albuminuria less than, sir, 30 milligram per gram. And, sir, type 1 diabetic patients, sir, around 7 to 25 patients will be, sir, non-diabetic, non-proteinuric.
Type 1?
7 to 25% in
Type 1.
So, and around 50% type 2, sir.
What is the normal staging of the diabetic nephropathy, and for which it is type 1, type 2?
Sir, it's basically, sir, it's for Morganson, so it's for type 1, and so it's Five stages,
So,
sir.
non-proteinuric diabetic kidney disease is mainly for type 2 diabetes, not
Yeah.
for type 1. So you do the biopsy. When you say there is normal size kidney, the proteinuria is very less, absent of retinopathy, they turn out to be mainly chronic interstitial disease.
Yes.
Right? So before answering a question, think first and then answer. Now what are that Mogensen staging?
So stage 1 is a stage of hyperfiltration, then sir, stage 2 is a silent stage, stage 3 is a incipient, incipient stage, stage 4 is a overt stage, and stage 5 is a advanced kidney disease. And so also sir, based on the duration, they have sir, stage 1 to stage 2 patients, it took usually 5 years. Then sir, stage 1 to stage 3 it took around 10 years, sir, and stage 3 it's 15 to 20 years, and stage 4 20 to 25. Then sir, 1 to stage 5 sir, around 25 to 30 years, sir, patients have, sir.
So in type 1 diabetes, if you are having rapid rise in creatinine below 10 years, then you will do the biopsy.
Biopsies.
So this why that and what is the natural course of type 2 diabetic nephropathy?
So type 2 diabetic nephropathy patient may have, sir, at the time of presentation, patient has a
How
diabetic
much?
nephropathy.
How much? How many percent?
So around, sir,
3 to 10%, not more than that. And how many type 2 diabetic they will develop the diabetic nephropathy?
so around 70%, sir.
70%. Tell me the prevalence of diabetes in urban area and rural area in India.
Question is, if there are 100 diabetics, how many of them will develop diabetic kidney disease? बहुत basic question है. I said a diabetic patient is very difficult. You'll get this because they are common. Exam में
बताओ.
चलो जी
30 to 40%.
30 to 40. Yeah, about 40% would have. Not all, everybody. So why does everybody not develop diabetic kidney disease? That's the next question.
So,
Hmm?
so due to the interventions,
Due to
so medical intervention, and so
medical intervention. This presentation has when there was no medical
No,
intervention.
still.
There was no medical intervention.
Don't think that you're doing a good job. Despite you, they are not developing diabetic kidney. So there is it's a polymorphic disease we don't know, and there are some
Genetic.
genetic factors.
Genetic factors.
So yeah. So now tell us, what are the factors, high risk factors for developing diabetic kidney disease?
In your
One is-
patient, if
one
you want to
is-
say,
one is development of diabetic kidney disease, the other is progression. What are the high risk for development of diabetic kidney disease or the high risk for progression of kidney disease?
so high risk includes presence of hypertension. So then
आप development की बात बता रहे हो ना, development of kidney disease. Because we said 100% will not develop. So start off always with genetics. We just told you, no? So that's why we were asking in the face. Very important to tell pointedly in the family history. There is no family history of diabetes, no family history of diabetic kidney disease. So if there is family history of diabetes, they are high risk of diabetic kidney disease. If there is family history of diabetic kidney disease, the risk is even higher. Okay? For some reason that we still don't understand. Okay? Now, so we said genetic factors. What else? Then you said hypertension. What else?
Then so
Glycemic control.
index.
Glycemic control. What did the DCC trial में क्या बताया था?
DCCT,
Landmark.
UKPDS,
So-
पढ़ा? Yes, your diabetes case will run like this only. No, they will say,
Fairly
how will you prevent the diabetic nephropathy? Tell, no, tell. How will you
एक
come the question
factors
like?
पे, we'll just finish off the factors. Okay. So once there is a diabetic kidney disease patient. Okay. Which are the factors which have make him at a very high risk for progression?
Sir, high risk of progression, sir, patient has albuminuria.
Yes.
Sir,
See, greater the albuminuria, the faster the progression. What else?
sir, decrease GFR, then sir.
Yes. hypertension उससे पहले,
hypertension,
especially poorly controlled, which was there here.
poor glycemic control,
Yes, poor glycemic control. Then what else?
so advanced age,
Not sure. Advanced stage तो नहीं है. No. In fact,
Poorly
it's the other way
controlled.
around. If there's a 60-year-old patient who develops diabetes, very less likely to
Develop the diabetic kidney.
because some genetic protection is there. It's coming to you.
Diabetes, no how many, no, he doesn't develop, how many years he is diabetic, one person is diabetic, and you know he's diabetic from how many years that you are pretty sure he will not develop the diabetic kidney disease.
so
If don't have any complication, more than 30 years. So,
No, देखिए 40 years patient comes to you with diabetes. Diabetes is not at his kidneys are fine and you're not one of the best patients. HbA1c कराया ही नहीं है. So genetic factors. And one more important, smoking.
smoke.
Okay.
Yes.
For smokers, everybody knows they are going to have a poorer progression. All right. हाँ अब बताओ क्या.
now comes your prevention of diabetic nephropathy, right? The first thing, non-modifiable factor is your genetic factor.
Genetic.
Now comes hypertension, glycemic control, right?
Yes.
Now tell me the trials for glycemic control and in type 1 diabetes and in type 2 diabetes, and tell me the control of blood pressure in type 1 and type 2 diabetes.
So DCCT trial was done for type 1 diabetes mellitus, in which they have studied for 10 years, and patients were divided into two groups. One group was treated with intensive diabetic control, and second group was treated with conservative or kind of.
So what was the difference?
So in patient with intensive diabetic control, they have received IV insulin. They are on injection.
I want to know the result.
So in results, patients with
Because you have to explain the patient in your clinic.
patient with intensive diabetic control have less evidence of micro.
How much?
So around 75%.
So it's too much.
Sir, in retinopathy, and 40% decline in nephropathy after 10 years.
From normal to microalbuminuria, from micro to macro. You have to see somebody saying, Dr. Sahab, I'm taking your medicines, right? Still I develop this. So you can have a protective roll-off for just 30 to 40%. From normal albuminuria to micro, 30 to 40, micro to macro, 30 to 40. Same was with the UKPDS trial.
Yes.
Right? And prior to coming your this SGLT inhibitors and finerenone, there was basically only two drugs was there, na? Intensive glycemic control and ACE or ARBs. And which was the trial with ACE and ARBs?
So renal trial, sir.
What was that?
3 trials: IDNT, renal, and more importantly, what was the residual risk of progression of diabetic kidney disease in these trials, despite even in the intervention arm? What are the 4 pillars now of management of diabetic kidney disease? सारे तो बता दिए गए, but
Bata.
first pillar is what? 4 pillars बताने हैं आपने जल्दी. It could be a theory question also this time. This is now
So SGLT2 inhibitors.
first pillar. Historically, cost-wise, everything. ASAPs,
ASMR.
not other things. Second pillar.
So second is SGLT2 inhibitors.
Okay.
Then third is MRA. Then fourth is GLP-1.
Yeah.
Good.
All right. How do SGLT2 inhibitors act?
So SGLT2 inhibitors, they act on SGLT2 receptors on proximal tubules. So basically, when in absence of SGLT2, there is increased absorption of sugar and
How many types of SGLT2 receptors are there?
So I think four types.
Okay. दो आपने डिस्कवर किए क्या? 2 types, SGLT1
One
and
and two.
2. अभी तो maybe 4 when you we do some research, but अभी तो 2 ही हैं. Okay. So now how do they act, SGLT2?
So they basically, sir, they block the
SGLT2. They bind to the SGLT2 receptor. Then what happens if they bind?
so then there is a afferent arterial
No. What is the function of this receptor? ना ये उसी से पता चलेगा.
So SGLT2 receptors basically, sir, they absorb the sodium and potassium, sir. Sodium and sugar, sir.
Sodium glucose transporter. No?
Yes, sir. Sodium and glucose, sir.
So now the receptors are blocked.
Yes, sir.
What
Then-
happens?
So there is a natriuresis, then sir glucosuria effect होगा.
Glycosuria and natriuresis. Now what happens?
Sir, then sir there is decrease in sir with sir natriuresis and sir glycosuria effect, decrease in sir glomerular pressure and sir.
ये क्या फीडबैक
Blood pressure कैसे होगा? अभी
कैसे
तो
होगा?
before
कुछ तो
that
होगा
what
ना।
happens?
कुछ तो कैसे होगा, कहाँ पे जाएगा वो ज्यादा सोडियम और जो आपका ग्लूकोज है, वेयर इट विल गो?
Increase in sir load of the sir macular densa, then
Good. So it goes to the macula densa, which is then what?
sir in response to sir high sodium and glucose, sir it will sir vasoconstrict the afferent arteriole and
Good.
they decrease the sir GFR, sir.
So it acts at the afferent arteriole. And how do these ACE and ARBs act?
So ACE and ARBs act at the sir afferent arteriole vasoconstriction, sir, and they
क्या करते हैं वहाँ पे?
sir afferent arteriole vasoconstriction, sir.
इफरेंट आर्टियल्स वैसो
Constriction.
Constriction कर. ठीक है.
वैसो कंस्ट्रिक्शन से क्या होगा? इंट्राग्लोमेरुलर प्रेशर बढ़ेगा, कम होगा?
Sir, but
इफरेंट
efferent, sir.
the ACRBs, they will act at the efferent vasodilatation. They will do the
They inhibit
vasodilatation.
the vasoconstriction, vasodilatation. That is why there is a synergy. उल्टा बोल रहे हो.
Yes.
Okay, so this is SGLT2 inhibitors. Now come to the next. So we have discussed ACE inhibitors, we have discussed SGLT2. Number 3 we said finerenone.
Finerenone.
How does finerenone act?
So they basically sir act on the sir mineralocorticoid receptor blocker, sir.
Okay.
And so thus they prevent the sir action of aldosterone, sir, and thus prevent the sir fibrosis and sir.
So there are 3 pathways for progression. One is the hemodynamic pathway, which is targeted by ACE/ARBs. There is the metabolic pathway, which is by the SGLT2 inhibitors, and SGLT2 also target the hemodynamic pathway. And the third is inflammatory pathway, and this is why these are unique. They target the inflammatory pathway. How do they do that? So they block the aldosterone receptor. Then what happens?
So decrease in sir inflammation and sir decrease interstitial fibrosis, then sir
How?
एक स्टेप पूछेंगे तो famous. Which are the trials which looked at? Which was the trial with MRA?
so Fidelio trial and sir Figaro trial.
Okay,
There was 2
chalo,
trials.
next. Now move on to your fourth pillar, GLP-1. How do they act?
So they act on the sir basically intestinal GLP, and so they decrease the sir they increase the sir insulin secretion and so decrease the glucagon and also decrease the satiety of the patients. And,
इसको पढ़ो यार अच्छे से. You should know each and everything. See,
Which are the trials now with GLP-1?
so flow trial, sir.
No trial.
what was the result?
What was the outcome? Protective effect. How did it reduce? Microalbuminuria reduction था ना? Cardioprotection था? What is the mechanism? पढ़ना पड़ेगा. ठीक है?
Any question?
Any doubts,
Anything?
questions?
In diabetic, when you're taking the case of diabetes, now the history should be like this: from how much time she or he is diabetic, on which drugs she is, whether it is poorly
Look into the
controlled
drug
or not
history,
controlled.
yes.
Then comes to the complication, macro, micro, and autonomic. Your presentation should be like this. But your presentation was more like that you are presenting a case summary sort of. Matlab, you was not coming in this way. A diabetic patient should come in this way.
Fairly predictable.
Macro, macro, micro, autonomic dysfunction.
Yeah, that
And-
we will discuss.
Yeah.
Because there is nothing.
Diabetic, you know, only thing you will go in theory.
Okay.
And
all
it's your
this-
bread and butter.
Trials you should read up. Mechanism of renoprotection of GLP-1. Okay. Pleiotropic benefits of SGLT2 inhibitors. Separate, maybe a theory question, or they'll ask you in the exam also. Beyond. You know, क्या होते हैं और benefits क्या होते हैं SGLT2 के और क्या?
Sir, anti-inflammatory, then sir, decrease
Improves
decrease
hemoglobin, blood pressure control,
cardiovascular,
weight loss, yeah.
then sir, improve.
Fatty liver.
बहुत सारे हैं.
So, कुछ पूछ, anything you want to ask? Anything you people want to ask?
Biomarkers for last question. Biomarkers for diabetic kidney disease now. एक तो बोला है वो तो बोल दो माइक्रो अल्मीरिया तो बोलोगे देन व्हाट एल्स give you a hint proteomics so they have looked at CKD they looked at the urine and they processed it through proteomics and they were able to identify 273 unique molecules so it's called CKD 273 so it's now being this test is now being evaluated in trials it's a research where they found some 273 polypeptide what was it so it's called CKD 273 I remember so that is an evolving biomarker in times to come. Okay?
Done.
Done.
Okay, thank you.
Okay, thank you.
Thank you very
ठीक
much.
है.
Just थोड़ा सा improvement, nothing more
ठीक है.
than that.
चलो.
I'm going to presenting case of Mrs. SS, 58-year-old female, married.